And we're back. We have Marc Surdyka. Marc, how you doing, man?
I'm doing well, Chris. Thanks for having me back on the pod. How are you doing?
I'm great. I'm excited for this conversation.
Me too.
We are going to talk about Stu McGill and this podcast he was recently on. He was interviewed on the Drive podcast that Peter Attia hosts, and a lot was said on both ends. It's almost a 3-hour podcast. We are not going to address everything because there's just too much, but Marc and I decided that there's a few topics that we can try to provide our thoughts, research, pros, cons of what was stated and claimed in the episode. For anyone who doesn't know Stu McGill, I looked at his website and his CV, so I'm just going to list what his kind of current experience and titles are. So he was a professor at University of Waterloo in Canada for 30 years. I believe he's currently retired now. Primarily did research in low back related injuries, and per the website, both intact humans and harvested tissues. He performed different studies. He's currently the chief scientific officer at BackFit Pro, which is his company, which, looking at the website, it's a variety of educational information for clinicians and I think everyday people. So that's a little bit on Stu. Peter Attia, the host of the podcast, he's a physician, or was a physician. I think he did like oncology based surgery, and he has a very good background. I don't think he practices whatsoever anymore, and just writes books, hosts podcasts, and
I think he does practice very selectively, and
as a physician. Okay.
But the purpose is maybe longevity. Like that's what he's all about, is just like maximizing lifespan. So your total years alive, but also your health span. So maintaining good health throughout your lifespan. That's my understanding. Like I've seen posts and comments with him and like Hugh Jackman and other celebrities. So he might have very, selective clients.
Got it. Yeah, his initial training, he was a surgical oncology fellow at the National Cancer Institute. General surgery was his training before that at Johns Hopkins. So now it doesn't sound like he does any of that. Let's just start with the big thing. I think this one's gotten the most. Go ahead.
I'm going to give my usual disclaimers.
Sure. Let's do it.
So I don't know all of Peter Attia's beliefs, but I will say that I've listened to and enjoyed many of his podcast episodes, like voluntarily, listen to and enjoy those episodes. People might say, why aren't you giving Stu McGill an opportunity to defend himself? First of all, we're not attacking him. Second of all, Chris did reach out to Stu, asked him or invited him to be on the podcast. Obviously, Stu is not on the podcast here with us today. So you have to understand that it's very difficult to initiate these conversations with individuals. We're always willing to discuss differences of opinions with people, but that doesn't necessarily mean they want to discuss those differences of opinions. With that being said, like I said, we're not attacking Stu. We're discussing ideas and beliefs that were discussed on the podcast. And I know some people get somewhat upset or emotional about these kinds of discussions, but I think it's important and probably arguably our responsibility as healthcare professionals with a large platform to dispel misinformation. And I would argue that those same people that might get upset or emotional about these kinds of discussions of, they might describe it as like bickering or this infighting, would be completely okay if a surgeon went on a podcast and said, nobody needs rehab after an ACL reconstruction. I think they would come to our defense if we said, no, that's misinformation. We need to dispel that. So I don't know why, if we dispel misinformation in this regard, that's any different. I think we can respect McGill and his research while understanding his limitations in his knowledge and what he teaches. And I want to highlight what Chris said, he was a researcher, a biomechanist. He is not a licensed healthcare provider. And one issue that I do take is that in this podcast, he states, with regards to his course that he teaches, that he doesn't care about your background to take his course, meaning that you could be a personal trainer, you could be a coach, you could be anybody, spend $4,500 for this 3-day course, and now treat individuals with low back pain. And that's not the topic of this discussion, but there are issues with that, right? You should be a licensed healthcare provider if you want to go that route. And the last thing that I want to say is that I'm going to take my time today, pause as needed, really gather my thoughts, because kind of as Chris alluded to, this was a 3-hour podcast episode. It was difficult to get through. It was difficult for us to organize a coherent outline for us to discuss, and even trying to gather my own thoughts about what to address within that outline was a challenge. So we're going to try to be thorough but concise with as much as we can get through in an hour, just shy of an hour. So with that, Chris, let's take it away.
Great. Yeah, and I'll add, Mark, you already mentioned it, but I did reach out to Stu about a week ago, right at the end of January, saying, I host this podcast for E3 Rehab. We would love to have you on the podcast to discuss the claims that were made within your most recent episode with Peter Attia. And he was nice enough to respond a few days later, said, I've been overwhelmed with messages since the podcast. Please forgive my delay. I'm booked for a podcast for a while. I'm driving 10 hours or so today, starting shortly. And that's always a good time to chat. And he gives me his personal cell phone number. So I didn't end up calling him that day. I was actually down for the count with COVID, but that to me was impressive that he would even send something like that. So giving him credit there to be open to even a phone call while he's driving. So I'll leave that there. But let's start.
If anybody wants his number, his phone number is...
That's right.
Okay, well, no.
I think he puts it on his website. I was looking at his CV. I think it's on his CV, unless it's just like, his assistant or someone.
Probably.
He seems very open to phone calls. Okay. We linked the podcast in the show notes. So if anyone does want to watch it or listen to it, it's there. And we'll kind of give general timelines if they want to listen to what parts we discuss. So around an hour and 20 minutes in, Peter asks Stu about his general thoughts of squats and deadlifts. And this is what's gotten a lot of controversy and traction over the past few weeks, of Stu making some claims about deadlifts, particularly in older adults. It essentially not recommending for them, and how they're going to lead to XYZ, hip replacements, ultimate injury, etc. Mark, what were your overall thoughts during this section and what Stu was claiming?
Yeah, so as you said, the big takeaway that I gathered from that, and we're trying to be as honest with the representation of what was said as possible. We're not taking things out of context. We're not misrepresenting what he's saying. He suggested that if you're over the age of 50, you really shouldn't be deadlifting. He said that he asks clients, do you want to be able to pick your grandkids up when you're older? And if they respond yes, he states to them that they can't both, play with their grandkids and deadlift. They have to choose one or the other, seemingly because of how dangerous deadlifts are. And that's problematic. So there's a lot of things that we can talk about here. And I think the first one is, Chris, something that we've discussed on previous podcast episodes is, why are we creating a false dichotomy with squats and deadlifts in the first place? We're essentially saying you're either doing deadlifts or you're not. There's no middle ground. And we've talked about this with other exercises that are probably more controversial, like upright rows. We said, like, you're either doing upright rows or you're not, because they're good or they're bad. And with deadlifts, there are just so many things that we could modify and so many discussions that we could have about safely and appropriately applying deadlifts in somebody's resistance training program. What do I mean by that? Is that individuals over the age of 50, first of all, if they want to go for PRs and they want to go for a 1 rep max, I don't see the reason why they shouldn't be able to do that. But even if we argued against that, well, there's a whole host of rep ranges. They could do, 5 reps. They could do 7 reps. They could do 10 reps. They could do 12 reps. Those reps never have to reach an RPE 10. So we're taking into account the overall load, like the intensity relative to what that person's capable of. But we could also consider the efforts. When we say deadlifts, are we strictly referring to barbell deadlifts? And if we are we only referring to barbell deadlifts from the ground? Could we barbell deadlift off some plates or some boxes so it's a shorter range of motion? Could we kettlebell deadlift or dumbbell deadlift? So I think that's really the first problem here, is this false dichotomy of you either do deadlifts for these PRs, which I interpreted as high intensity, low repetitions, which once again, I don't find that problematic, but there's so many ways that you can program deadlifts. And I think from Stu's perspective, it seems like he sees a lot of powerlifters and maybe high level powerlifters. So maybe he's viewing it from that lens, but it's such a myopic view and such a narrow lens that I find that claim problematic just from that perspective. What are your thoughts on that?
Yeah, I agree with you. I think it was in this section where he just reorients essentially a client's goals for them. He frames it as like, do you want to pick up your kids? And you can't have both. You can't be really strong deadlifting and you can't pick up your kids as a grandparent or whatever it is. And yeah, it's just instilling so much unnecessary fear and black and white, yes or no, to a spectrum. And it's like, fuck, you're picking up your kid. You're literally picking something up. That's a hinge. That's a deadlift. So how do you frame deadlifts as this evil thing as you age when they're performing a movement that is a deadlift if you're making the goal to pick up the children? That's my general thoughts. I could have added this somewhere else, but I think it's a good place where one of our prior guests more recently, Laura John Gregorio, she's at University of Waterloo, where Stu McGill used to teach and research, and she fully promotes deadlifts and resistance training and heavy resistance training for older adults and these adults that have osteoporosis and osteopenia. And you can listen to that episode and hear her thoughts. She was one of the lead authors on Canada's osteoporosis and fracture prevention guidelines. So it's an expert. She has a PhD, that her life is spent researching these things, and these individuals that are quote unquote at high risk for potentially getting fractures, she's promoting this gradual progression in compound resisted exercise in your later stages of life. So I'll leave it there.
Yeah, Chris. And as I kind of already alluded to, I think he's trying to think of deadlifts in the most extreme example, which once again might not even be problematic, but it would almost be saying that, hey, my goal is to hike and I have a hip replacement. And then someone telling me, well, you shouldn't go hike Mount Everest. Like, you shouldn't hike at all, because in their mind, I'm going to go hike Mount Everest, which might be fine. But what if I'm like, I just want to hike a mile or 2 miles? It's like the super extreme example when there's so much in between. And so going back to what you mentioned as well is resistance training in older adults. There's the Lift More trials, which I've made YouTube videos, maybe just one YouTube video on in the past. And these are by Harding and Watson. And there's a whole bunch of different articles, but there's 2 primary studies. And I'm going to kind of read what they did in this study or in these studies, and then what they found. Because if we're going to say that deadlifting is unsafe for older individuals, we should base that on the data. And the data says otherwise. So these two studies, the first study examined healthy postmenopausal women over the age of 58 who were classified as having osteopenia or osteoporosis at their hip or spine. The hip is important too, because we're going to talk about that. The second study examined otherwise healthy men over the age of 45 who exhibited osteopenia or osteoporosis at the lumbar spine or proximal femur. Both groups underwent 8 months of high-intensity resistance and impact training with a 1 to 2 month familiarization period. So they did build up to learn the movements, technique, and slowly ramp up. Twice per week, the participants completed 30-minute supervised sessions that included deadlifts, squats, overhead presses, and jumping chin-ups with drop landings. The barbell-based movements consisted of 5 sets of 5 repetitions at 80 to 85% of their 1 rep max or greater. And they were asked to keep their rating of perceived exertion high. If they were able to perform 7 repetitions with acceptable form, I don't know what acceptable form was for them, weight was progressed by 2.5 kilograms. Now, they had a lot of outcome measures, but here's the 2 most important things. The high intensity resistance and impact training did not cause any fractures in the males or females. And for those who had vertebral fractures at baseline, so some of these participants came into the study with vertebral fractures, there was no progression in severity of those vertebral fractures with the impact landings or the squats or the deadlifts or the overhead press. So that's the first thing. The second thing, over the course of thousands of training sessions across all of the participants, there were only 3 minor adverse events: 2 mild low back strains and 1 case of knee soreness that resulted in a total of 4 missed sessions, which is pretty impressive. I've probably had a low back strain in the past 8 months just from sitting at my desk for too long or so. So to think that this is dangerous in older individuals, I think is just not based on the data that we have.
What else with this general theme, if we want to stay with the deadlifts and squats, what other concerns are there with some of the claims being made?
Another one, and he didn't say this exactly. So this is what I'm saying. Like, I want to try to represent Stu McGill as best as I can. But from my interpretation of how he speaks, not just on this podcast, but on others, it's almost as if discs don't have the potential for any type of positive adaptation. And if we look at the data, we do see that discs can have positive adaptation to different activities and different stressors. And even if we didn't look at the data and we looked at this from a logical perspective, and Stu is working with these high-level powerlifters, if the first time that powerlifter picked up a bar and let's say they did a 135-pound deadlift and they progressed all the way up to 700 pounds, 800 pounds, 900 pounds, 1,000 pounds, you would expect somewhere along the way when they took 135 pounds and progressed that to 800, 900, 1,000 pounds, that something in their spine and something in those discs is adapting to at least some degree in order for them to be able to do that safely. If not, wouldn't their discs just potentially, explode from the heavy load? So that's one thing, is that we view these discs as not being able to adapt. The other issue that I took here was that he tied this into who's having hip replacements. And I don't have his exact quote, but he essentially said that if you continue deadlifting and squatting, you're going to go on to have artificial hips, is what he said, hip replacements. And then he kind of asked a rhetorical question to Peter saying, who's having their hips replaced? It's people who do yoga, and it's people who do powerlifters, and they're like men in their 50s who are powerlifters. And two problems with this. At the very start of the podcast, or maybe earlier on in the podcast, Peter asked Stu a question, and Stu basically said that he does not look at the epidemiology of low back pain, and he does not look at the prognostic factors related to low back pain. Instead, he only considers the patients in front of him. So if Stu is unfamiliar with the epidemiologic data related to who's getting their hips replaced, well, if the people that are coming to visit him are powerlifters and, let's say, people who do yoga who have hip replacements, sure, it makes sense for him to say those are the people who are getting hip replacements. It'd be the same thing for me. I've done most of my practice here in Los Angeles. If I said, yeah, everyone who goes to physical therapy has also done Pilates and yoga and chiropractic care and all of these other things that people do in LA, that's just my experience. That doesn't extrapolate to the rest of the country or the rest of the world. And so, do some individuals who have done yoga and powerlift end up getting their hips replaced? Sure. Is it because of that? Maybe, maybe not. I don't know. But if we look at the data, it's people in their late 60s, 70s who are getting these hips, their hips replaced, and it's not necessarily related to powerlifting or yoga. So there's a big blind spot there with him that he admits that he doesn't even look at this data. He just looks at the people in front of him. So that's going to lead to some maybe error in reasoning, some biases there. And he also goes on to state that people who practice yoga should stay away from heavy loads. And this is like a conversation that we weren't going to necessarily get into, because he talks about like you're either a bendable spine or a more stiff spine. And if you have a bendable spine, like someone who does yoga, you shouldn't do heavy resistance training. And that's just a bad message to promote as well, because we know that women, especially perimenopausal, postmenopausal, should be doing resistance training to try to prevent osteopenia, osteoporosis, and down the line, a risk of falls. So all of that is a little bit frustrating. You want me to keep going, or do you want to comment on any of that?
Yeah, I'll add to that. He essentially framed it as stay with the adaptation you're seeking or your anatomy provides you. So these bendy, flexible yogis, they should stay doing those tasks, and the powerlifters should stay doing those things. And there shouldn't be essentially like cross-contamination with this assumption that there's going to be this adverse spine response. But there's probably countless examples of athletes and people throughout their lifespan that do so many varied activities. And now there's so many hybrid athletes that are doing all the things. And it's just, I don't know how he can make that claim by just putting, again, people in these buckets and these black and whites of you can only do this thing if you transition over to attempting something that you haven't yet tried, or inherently your spine hasn't adapted to, you're going to get injured. And what I will go off this point, he mentioned in another part of the podcast how he loves using pro athletes as examples for what normal people should or are capable of. And it's just so wild that he uses these professional like freaks as examples, and essentially to show how adaptable this spine can be and is. But then he does and says complete opposite messaging, essentially instilling like fragility of spines on average. I don't know if you have thoughts there, Mark, but I think that's good tie-in.
Yeah, it's like telling a runner they shouldn't do any resistance training because they're built for endurance, and then telling somebody who does resistance training that they shouldn't do any endurance because they're built for resistance training. And it actually contradicts some of what he says, because later on in that same section, he says who's not getting their hips replaced? Moderates, meaning that like people who are just moderately physically active and don't try to go to the extremes. And to some extent, I agree with that statement in the sense that if you are training for high-end performance, you're not always placing your health first. And so, yeah, there is going to be some inherent risk involved if you're trying to be a gold medal Olympic athlete in certain sports, or you're trying, we just had the Super Bowl here in the United States. You're trying to, win the Super Bowl. We saw a lot of injuries just within that game because they're playing in a super high stakes game, peak performance. Yeah, of course, the injury risk is going to be a little bit higher. And that same token, if you're completely sedentary and you're not exercising at all, yeah, your risk is probably a little bit higher for certain conditions too. So, of course, being moderate I don't even know how to define that, right? But like just generally being active and meeting different guidelines, but it's just a little bit contradictory with everything else that he states there. And I do want to touch on what Peter said a little bit, and we've already kind of discussed this, but 3 things, and these are quotes from Peter in the podcast episode as he's pitching the question to Stu, is you can do other exercises that aren't deadlifts because you don't have a fraction of the axial load. Axial load meaning, let's say with a squat, barbell on your back, there's some axial load, there's the compression on your spine. And the question I would ask is, why is that viewed as a bad thing and not necessarily something that we can adapt to? And if it is viewed as this dichotomous good or bad, how much axial load is too much axial load? Because I've listened to Peter's podcast and I know he's a big fan of rucking, and rucking involves wearing a weighted like backpack essentially and going on mile-long hikes. So he's okay with axial load from that perspective, but when it comes to squatting, he's not okay with that. But as we just saw with elderly women with osteopenia and osteoporosis, they did it safely. He also says that doing exercises as alternatives to deadlifts are the lower risk approach. And then he says, for the deadlift, there's a narrow operating window in which you can hurt yourself. And once again, I don't know where these statements are coming from. They're not coming from data. And I could probably surmise where those beliefs are coming from. But are these same individuals also denouncing all sports? Because we know that just playing organized sport is more injurious than squatting or deadlifting. And I don't think Kristen or I are arguing that anybody has to barbell back squat or anybody has to barbell deadlift. I personally, if you want to do it, go for it. If you don't want to do it, I don't care. I don't care either way, but it's having the knowledge to know that those things are fine if they fit your goals and it's something that you enjoy and you want to do.
Do you want to go into the big 3?
Let's go on to the big 3.
Let's rock. For those who want to listen to the episode, it's around an hour in. Peter begins by asking, Peter states early on at the beginning of the episode his experience with excruciating low back pain and how now he's done 2 of the big 3 for quite a long time, and then kind of asks Stu, is it fair to assume that these big 3 should be done preventatively before someone has back pain? And Stu has a really quick retort saying, no, I want to address that and kind of shut it down. Each person has a different, I don't know if he said big 3, but essentially framing it as depending on the person's makeup and structure, there's going to be these quote unquote protective or, stability based exercises for each person. So he wasn't explaining that the traditional Stu McGill big 3 is for everyone at all times, but it was still very much framing it as like there are these things that should be done depending on the person's kind of structure and anatomy and build. Where do you want to go from there, Mark? Where should we start here?
Yeah, there's probably 5 different topics that we could go off of this, and I don't know if we need to spend the rest of the time on these 5 different topics. I think let's start with the basic one, is that in this podcast, Stu is operating largely, from what I gathered, based on his anecdotes. He is not citing research very often in this podcast episode. And when he does cite research, it's usually related to some of the biomechanical data that he looked at. And we're going to get into that with kind of the next thing that we're going to talk about. The reason I say that, and this is not a stab at McGill, the reason I say that is that when we look at the data, trying to do core stability type exercises is not better than other methods of exercise. And Chris can touch on this in a little bit if he wants to, related to some of the clinical practice guidelines and the Lancet series. But McGill's a researcher. If he wanted to show and prove that the McGill Big Three are superior to other methods of exercise, he can do that. He can do a randomized control trial and flesh that out for us, but that's just not been shown. And so, do you want to touch on maybe recommendations real quick? Because once again, there's so much to talk about.
Yeah, we might as well. To Mark's point, what is wild about an almost 3-hour podcast is there's really no reference to any national guidelines, any consensus statements, any systematic reviews on the topic of low back pain management, prognosis, natural history. It is these stories and, one-handed personal accounts that Stu's having, which sound interesting. They're stories. People like stories, but there's no rooting of significant supporting evidence besides, as Mark mentioned, some of Stu's personal biomechanical studies that he referenced, and a lot of them in cadavers. What I think is beneficial is to let's zoom out and look at these national and international guidelines and consensus statements and what are they finding. And there's so much that we could discuss, but I think some big things are, if we're going to discuss the big three, the McGill Big Three, or just general stabilization exercises, when this is studied and looked at throughout multiple studies, throughout multiple systematic reviews, is it superior to other exercises in general? And we'll link these in the show notes, but there was a systematic review of systematic reviews by Grutin et al. In 2022, looking at exercise and chronic low back pain. And the findings, they looked at aerobic training, aquatic exercise, motor control exercises, Pilates, resistance training, yoga, walking. Quote, our findings show that the effect of various exercise types used in chronic low back pain on pain and disability varies with no major difference between exercise types. And then they go on to proceed that so many of these studies, there's high risk of bias, there's low to very low moderate quality, but this is kind of a recurring theme in the literature that it really doesn't matter what exercise is utilized or what movement. There is a general theme of a positive trajectory of patients' outcomes, but we can't find one specific exercise. There was another systematic review of systematic reviews looking at acute low back pain and exercise by Carlson et al. In 2020. Quote, the body of evidence from 24 systematic reviews consistently shows that exercise therapy in the acute phase of low back pain does not yield any clinically important difference compared with any other treatment for most outcomes and most time points. The most likely explanation for the lack of effect is the generally good prognosis, aka the natural course of acute low back pain.
Can I stop you there?
Sure.
I think what you just said is very important, and it ties back in with what I said earlier, that Stu said that he doesn't look at the prognostic related data related to low back pain. So let's say someone does the McGill Big Three when they have acute low back pain. Likely their back pain was going to improve anyway. So maybe he sees somebody and he says, hey, you should do the McGill Big Three. You have low back pain, and they get better. Well, without knowing that people are generally going to improve anyway, he might attribute that success or that improvement in symptoms to the McGill Big Three. So that's one issue. I'm gonna list a few issues, and then we can build off of it as needed. When you present anecdote as your evidence, one, we could probably dismiss it to some extent, or I could counter it with my own anecdote. And anecdotes of people saying, I tried the McGill Big Three and it didn't help. Or I tried the McGill Big Three and it made my symptoms worse. The Physio Matters podcast, I was trying to find the episode. I don't know if you've listened to it before, but they had an episode of a patient who had, or an individual who had persistent low back pain. And he told his story about, really going through all these methods in the McGill Big Three and having these evaluations and trying to keep his spine super stiff, and it just ended up making things worse. So sure, he could have this anecdote of helping somebody out, but there's also the anecdotes of the opposite. And it's not to say that the McGill Big Three can't help some people. It's not to say that Chris or I don't prescribe side planks to people. Of course we do. But the issue might be if the messaging is interpreted the wrong way by the patient, or if it's just delivered inappropriately by the provider, is that it might create fear and catastrophizing around spinal movement and the idea that you have to maintain the spinal neutral, which we know is impossible. When you're squatting, when you're deadlifting, when you're doing kettlebell swings and there's research by McGill that shows that trying to maintain this quote unquote neutral lumbar spine is not possible during these movements. And that's during these, I'm going to say, fairly simple resistance training exercises. Now we take that to sports or more dynamic movements, and we're probably going to see that quote unquote neutral spine even less. So there's a problem there with saying that, hey, the purpose of this is try to maintain this neutral spine, when that's not necessarily how things are necessarily performed in the gym or on the field. And it's not to say that they don't have benefit. Like I said, I'm sure they can have benefit for different reasons, but there's problems with that too. And I think the other thing that I want to point out is that at one point in the podcast, he says that surgery may work for certain individuals because it's forced rest. Now, I don't know everybody that Stu McGill has worked with, but I have seen case studies that he's discussed or people who have, written about it, where maybe they are power lifters and they stop powerlifting for a prolonged period of time to go on a regular walking program, intermittent walking, which I think is great, and do the McGill Big Three, which if you went from powerlifting really heavy weights to not doing that at all and instead walking and doing the McGill Big Three, to me, that is kind of like forced rest. And he even gives an example. Once again, I don't have the quote in front of me, but he talks about these two gymnasts who are preparing for the Olympics, and they both have low back pain. And he essentially states that the one that continues preparing for the Olympics over the next 6 months, you would expect that they're going to do a lot worse than the one that takes time off of training to work on stabilizing their spine. And it's like, yeah, of course, gymnastics is hard work and your spine is doing crazy things. If you have pain with every time you hyperextend your spine, but you're preparing for the Olympics, you either have the option of, like I said, if you're training for performance, there's some risks involved. But if you just say, okay, I'm going to take 6 months off, well, that's forced rest. And I don't think he sees the similarities there with what he's describing between some of the things that he's discussing.
Adding to that, what was already mentioned, there's not one exercise that is superior from a research perspective. And a lot of these big recommendation guidelines recommend exercise that patients and clients value and have access to and enjoy. And that, I think, is something that's concerning for the big three, is it's very much limiting the enjoyment of movement and rehab and the day-to-day. The Lancet series, I think it was 2018, 2019. It was a multi-part series on low back pain. They have a quote, which I think sums this up nicely, is, quote, "Since evidence showing that one form of exercise is better than another is not available, guidelines recommend exercise programs that take individuals' needs, preferences, and capabilities into account in deciding about the type of exercise." Another giant kind of standard of care and recommendation through Australian low back pain, the clinical care standard, which came out a year or two ago, they recommend something similar: practice points for recommending exercise for patients. Exercise programs should be individualized, taking into account the patient's physical activity preferences, beliefs, and specific functional impairments. There's nothing within these major national and international guidelines that recommend this XYZ specific exercise or the McGill Big Three. If anything, it should just provide relief for the patient and for clinicians that if they want to do the McGill Big Three, they can. It's not harmful, but it's not magical. There's so much other things to explore and to experiment with and to have a trial and error that it should feel freeing, as opposed to locking us down into this stable, rigid system and narrow bandwidth of exercises.
I think people listen to what we're saying. Some people listen to what we're saying and think that we're taking things off the table. If anything, I think we're putting more things on the table, because I know you just had a discussion with Aaron Kubal about, you know what, nerve glides probably aren't that special based on the research. So you don't necessarily have to do them. But by the same token, if you do them and they make you feel better, it's okay to do them. If you try the McGill Big Three and you find that it makes your symptoms feel a little bit better, that's also okay. We just have to understand the limitations of why it's helping. It might not be helping because of this shearing of your intervertebral discs and this concept of core stability, but it's helping for all of these other reasons. That's fine. And two more points that I want to make is that we know that people with low back pain often move more rigidly. We have research that shows that, right? That they're going to move a little bit slower, a little bit more cautiously. And you've had Peter O'Sullivan on the podcast before to talk about some of his research. And if you watch demonstrations by Peter on YouTube, and admittedly, I'm not always the biggest fan of demonstrations. Like Stu talks about them. I know Peter talks about them. I've seen them in person. I know people do them at courses, but there's a host of issues to some extent with these demonstrations as well, because there is this expectation effect, etc. But demonstrations aside, one thing that Peter highlights for himself is that oftentimes he tries to give people permission to move however they feel like moving, because they've been conditioned to believe that they have to maintain some level of rigidity and bracing in order to protect their spine. And when they're given this permission, just move how you want to move, sometimes they feel better. The last thing that I want to say is back to these anecdotes, is that there are so many appeals to anecdotes in this podcast episode. This section specifically, I don't think he said that he's worked with Usain Bolt, but I think he mentioned that he saw Usain Bolt doing a bird dog and then stood up to demonstrate how, like, he's insinuating that bird dog contributed to Usain Bolt's success as a sprinter. And he stood up and showed how the bird dog looks like, sprinting off the blocks. And it's, yeah, it's just, you can't make that leap by any means.
He made leaps the other way of, I think it was at a different point, but discussing I think it was in regards to like ass-to-grass squats or some type of training, how it essentially quote unquote D2s athletes and sets them up for failure and makes them at a higher chance of not living up to their potential going quote unquote D1. I don't remember where in that podcast, but it's something similar of just this wild claim saying that this is going to lead to this, or for Usain's case, like this has led to his excellence. It happened multiple times in the episode.
I think the D2 thing was D2 meaning that if an athlete's going to go on to D1, which is like the highest level of college sports, D2 meaning they don't reach their potential. I think that example was just related to barbell deadlifting and barbell back squatting. He mentioned the ass-to-grass squat in relation to hockey players that he observed over several years. And the example that he gave was that he would observe these athletes, and if he observed these athletes for 8 years, and 1 year someone came in, let's say on year 5, and they had low back pain, and he asked questions, and that hockey player said, oh yeah, this year I've been doing ass-to-grass squats with our strength and conditioning coach. McGill said, aha, that's the thing. You did these ass-to-grass squats. You're creating these negative adaptations in your discs. That's why you're experiencing low back pain here, right? Like it's like this immediate conclusion that you just can't make. Let's go on to the next thing, I think.
Let's do it. Disc bulge, vacuum and disc bulge. Is that where you want to go?
Yeah.
You start out with what was he claiming about the ability to vacuum up a disc bulge in this episode?
So, yeah, so he's saying, and he used the word, the phrase vacuuming in a disc bulge. And he was saying that you can do this by one of two mechanisms, if I understood him correctly. One, lying on your stomach and just breathing, or lying on your stomach and having someone traction your legs. And that would vacuum in the disc bulge. So unrelated to Stu's claims, first of all, we know that traction isn't anything special as well. If we look at the research, for some people, maybe it works. For some people, maybe it doesn't. And that's what Stu says that for a lot of things in this episode too, right? He's like very confident in his McGill Big 3 and some of his methodology, but then he also gives a caveat of like, well, this doesn't work for some people. And it's, well, yeah, of course not. So I tried to find this claim because he said that this is research that came out of his lab. I looked. I could not find it. So I asked other people, and someone else found what they thought, because they also wanted to find it. They sent me what they thought was what he was talking about. And the title of this paper was Disc Prolapse, Evidence of Reversal with Repeated Extension. This is the closest thing that I could find, or that someone found for me, related to the claim being made. And essentially, they're just taking a cadaver, which is, the certain part of the pig spine. They're putting it in this contraption. They're adding a compressive load, like kind of like this axial load, and then they try to induce a disc prolapse with repeated flexion or some repeated flexion and side bending. And then they did this, and then they wanted to see if they could move that disc prolapse back in a little bit with repeated extension. So that was the only thing that I found, was this cadaveric research as it relates to this claim about vacuuming in a disc bulge, which I don't have problem with cadaveric research. I don't have problems with biomechanical research. Like, all of that research is very important, and it helps drive theories, and it helps drive other things, that hypotheses that we should test. But we can't make the conclusion, and maybe it's another paper that he's talking about. Like I said, I couldn't find it. But if this is what he's talking about, we can't make the conclusion that doing this in this cadaver model in a very controlled environment is going to relate to lying on your stomach and having somebody pull your legs and wiggle it around in a different podcast episode that I listened to by him, not this Peter Attia podcast, because I wanted to get more context because he's talked about it before. And I wanted to find this paper. He was basically saying like a really skilled clinician will be able to pull and wiggle and twist your legs perfectly enough to get that disc like vacuuming back in. And I don't know where that's coming from.
I don't know either. And I don't have much more to add to that. Anything else you want to add there? Or should we just keep chipping along? Because there's so many things we could talk about.
Yeah, let's keep chipping along.
Okay. I'll leave this up to you. Do you want to go the route of longevity or non-specific low back pain?
Let's go non-specific low back pain, but just quickly, Peter asks Stu how to maintain longevity of the spine. And do you remember what his response? I don't exactly remember what his response was. It was something about avoiding fractures, maybe?
It was like the end plate. You have to have a healthy end plate.
Yeah, healthy end plate, like making sure you don't have a vertebral end plate fracture. And listen, there's so many things that you can do to maintain the longevity of your spine, but it's the same thing that you would do to maintain the longevity of the rest of your body, which is regular exercise, not smoking, probably, being born from parents with good genetics. So it's just all of the things that you would normally do to maintain your overall health anyway.
Non-specific low back pain. He mentions it multiple times in the episode that he doesn't believe there's such a thing as non-specific low back pain. I don't know if he ever gives a direct answer immediately after that. It always gets alluded back to the assumption there's always going to be a pathoanatomical, structural reason as to why there's back pain. Is that your kind of understanding as why he's explaining there's no such thing as non-specific low back pain?
Yeah. And should we try to describe or define non-specific low back pain first?
Yeah, let's do it.
I think typically when non-specific low back pain is used in the research, first of all, we're trying to rule out things that require specific medical management. So what are those things? A fracture, an infection, a tumor. Those, and there's other inflammatory conditions, etc. But those things might require specific medical management, and those things are specific reasons for low back pain. The non-specific diagnosis, and some argue that potentially like lumbar radiculopathy and maybe some other things also fall underneath more specific low back pain. And the non-specific would just be pain in the low back that doesn't necessarily require medical management and cannot be necessarily seen with a scan or a test or something along those lines. And it's really about identifying the modifiable variables in that person's life. To give a slightly different analogy, maybe in the shoulder, let's say, aside from fractures, infections, etc., maybe frozen shoulder would be something that requires specific management. Maybe someone does a corticosteroid injection acutely for a frozen shoulder. Maybe a dislocation of the shoulder, you're going to do surgery there. But for some of these other diagnoses, let's say shoulder impingement, subacromial pain syndrome, rotator cuff tendinopathy, rotator cuff tear, yada, 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 those things might fall underneath this umbrella of non-specific shoulder pain because they don't necessarily need a specific treatment strategy. I don't know if I did a good enough job of describing that, or if you want to read it from maybe like clinical practice guidelines or something.
Yeah. No, you did. But I think this quote will sum it up nicely as well. This is again from the Lancet series, which we will link in the show notes. This is their definition of non-specific low back pain, and they kind of give some meat around it to provide some other information. Quote, low back pain is a symptom, not a disease, and can result from several different known or unknown abnormalities or diseases. It is defined by the location of pain, typically between the lower rib margins and the buttocks creases. It is commonly accompanied by pain in one or both legs, and some people with low back pain have associated neurological symptoms in the lower limbs. Here's the definition for nonspecific low back pain. For nearly all people presenting with low back pain, the specific nociceptive source cannot be identified, and those affected are then classified as having nonspecific low back pain. There are some serious causes of persistent low back pain, i.e., malignancy, vertebral fracture, infection, or inflammatory disorders that require identification and specific targeting the cause, but these account for a very small proportion of cases. So, to Marc's point, there's so many structural, identifiable, potential things that could show up on imaging that could be a claim for why someone's having low back pain. But the majority of them fall under this umbrella of nonspecific because it doesn't change the treatment plan of care, and it's nearly impossible to strongly and confidently claim that one of those findings is the cause, because there's such a high base rate of these occurring in people that don't have symptoms. So you could take an MRI or an X-ray of thousands of people's spines across the lifespan, and things are just becoming more and more prevalent as they get older because it's just the aging process and it's very normal. So trying to identify which of these cases someone has these symptoms because of this MRI finding, you would have to do so many things to come to that conclusion that it's just nearly impossible, and it doesn't change treatment unless it's one of those red flags and things that would change treatment, which is such a small percentage of cases. It's typically reported as like 1% of the cases.
And nonspecific doesn't mean a nonspecific diagnosis doesn't mean nonspecific treatment or nonspecific management. The treatment and the management is always going to be in the context of that person's life and their lifestyles and their beliefs and maybe things that are aggravating their symptoms, right? So if you have a person that says, hey, Chris, every time I bend forward, my low back hurts, Chris is not going to say, well, it's nonspecific, it doesn't matter what you do. He's going to say, okay, well, let's find a way to work around this movement for the time being and see, hey, maybe if we do the opposite movement that feels great, let's figure that out. And I think that gets misconstrued sometimes as well, as that nonspecific just means like nothing matters, do whatever you want. It just means that we can't be as confident as often believed. And I think that's a couple issues with this statement from McGill, is that his assessments, I don't know what the reliability and the validity of his assessments are. If he's that confident in his assessments to diagnose and treat somebody, he should also have that information published. He should have it tested and published. But to my knowledge, it's not. It's basically, he took his time as a researcher and decided, like, I'm going to think on this and I'm going to develop a series of tests, and this is how I'm going to treat low back pain. But as far as I know, that hasn't been validated. And to some extent, he's treating people as if they have no nonspecific low back pain. So admittedly, I have not read his book, but he explains in the book that people can go through these series of self-tests and then they do different exercises or modifications for back pain. And to me, that kind of falls under the umbrella of nonspecific low back pain. If it's like, hey, do this self-test and reach forward 10 times, and if that hurts, don't reach forward as much and maybe do some extension if that feels, like it seems like he's describing treatment for nonspecific low back pain the way that he described it in the podcast episode. So once again, there's a little bit of a disconnect there.
And it goes back to what you mentioned a while back, Mark, of him not liking epidemiological or discussing epidemiology or talking about acute versus chronic low back pain or framing these things. where, again, going back to these guidelines and this research, one of the things that is most consistent along a lot of these is reassurance and education for patients with acute or chronic low back pain. And that's kind of the number one large recommendation of reassuring these individuals that they don't have the scary, concerning findings that would require more emergent medical attention, and reassurance that a lot of times there's a favorable natural history. This, for a lot of people, will start to improve over the next 2 to 6 weeks if this is an acute case. Sometimes it lingers longer for individuals if there's radicular symptoms or there's more nervy type things that may prolong. If someone has chronic pain, there's probably this kind of, fluctuating response over someone's life. And if it's acute, it may come on in the future. And to set these educational expectations and understanding of what we know and what we don't know as to why someone potentially got it. There's a lot of unknown of you can't fully establish why someone initially had or has repeat episodes in all cases. So it's anchoring the expectation and the education with these patients. Fortunately, there's no major red flags and concerns. These are the things I can reassure you on. I want you to be as active and return to work as quickly as we safely can. These are the options and strategies we can attempt. We have a lot of options, which is great. Let's experiment. And I think that should have been the biggest message in this podcast, of instilling reassurance, instilling confidence, providing a variety of options, as opposed to 3 hours of story and anatomy and not rooting this in any large scale research.
Yeah, our message is empowerment. And I've seen people say, well, what he said was taken out of context. But what I took away from that is that if you're over 50, you shouldn't deadlift or squat. If you want to avoid artificial hips, avoid deadlifting and squatting. If you do yoga, you shouldn't do resistance training. My interpretation is that the spine is inherently unstable and requires certain strategies unknown to the layperson to develop that stability. And if you don't have that stability, not only are you going to be at an increased risk for injury, but you're going to have reduced performance and a variety of, and there's just this list of things. And like you said, it isn't in line with the overall body of research. Anything else that you want to, I don't want to touch on some of these other terms. So just for context, there were other terms used like energy leakage, and we won't touch on that, but is there anything else that you want to touch on from some of that research in general?
No, I don't think so.
Okay. I don't think I have anything to add as well. I would say my conclusion, if we are going to leave people with some empowerment, is that it is safe to squat and deadlift, and it's safe to do so over the age of 50. It's safe to do so if you practice yoga, and we might even say it's encouraged to squat or deadlift or perform some level of resistance training throughout your life. And if you have pain, or if you have injury, or you have difficulties, understand that those movements aren't dichotomous, good and bad, and that there are ways that you can modify those movements, that any physical therapist, any strength and conditioning coach, any personal trainer could probably help you figure out how to modify those movements so that you can still do them and meet your goals. If the big three are helpful for you, or components of the big three are helpful for you, you can use those exercises. They're fine exercises to do, but they might not necessarily work for some of the reasons that were discussed in that podcast episode and elsewhere. If you want to maintain longevity of your spine, just try to be healthier overall. There's probably not anything specific that you have to do, and understand that we and every healthcare provider that you work with probably wants to validate your pain. And this is where I do agree with McGill. He mentioned that somebody told him that a doctor or somebody told the patient that the pain was in their head because they couldn't identify a finding for their pain. And we agree with that. You should never tell a patient that the pain is in their head. And I guess I don't know where I'm going with this other than that if you've been told that you have non-specific low back pain, it's not because someone doesn't believe you. It's hopefully because they were trying to encourage and empower you to say, listen, you don't have all of these other things that are scarier, which is a really good thing. And that means we have a lot of options to help you. Let me lay out those options and let's come up with a plan together to work, within those options. Because as Chris said, and based on the research, it's very common for people to have disc degeneration and disc herniations and these different changes on imaging that just occur with natural aging. And do they sometimes happen and they're associated with an acute injury? Of course. But in many cases, those are just incidental findings.
That was a great summary and wrap up. Let's call it there, Marc. Thanks for coming on. Thanks for powering through the 3-hour episode of watching it. We both watched it. Well, I watched it twice. The second time I watched it on 2 times speed, but I'm hoping people found this valuable and the message of we're not trying to attack Stu or Peter. We're trying to just discuss what was said in the episode and provide some alternative options and hear people's input and feedback.
And if you're looking for resources, Chris is linking those resources in the show notes. So read those. They're great.
Boom. We'll call it there. Thanks, Marc.